Okay, so we are live in 3, 2, 1. Hello to one and all today on behalf of MedSynapse community. Today is a very significant day. We are in the month which celebrates across a very pertinent topic in the healthcare ecosystem, that is gout. Being the Gout Awareness Month, we do have the privilege of having this masterclass session today live with a very designated keynote speaker. His name is Dr. Shakaib Quereshi. As all of you know, he has already done one session with us, which was one of the most appreciated session on our platform, that was diagnosis and management of rheumatoid arthritis. And today we are very lucky to have him with us. And just to give a brief introduction about today's keynote speaker, Dr. Shakaib Quereshi is a rheumatologist originally from Lahore, Pakistan, where he studied from King Edward Medical University and then immediately moved to the United States for further studies. He is a board certified internal medicine physician from Pittsburgh, as well as done his fellowship from University of Oklahoma. Having a board certification in rheumatology, he has also served as a section head for the department in 2017, and as well as the head of the program until 2019, where he has nurtured a very important concept, that is the Delaware's Association of Rheumatology, not only as the president, but also as one of the very functional institutional individual in this particular thought process. He has worked, apart from delivering various different protocols, teaching students and residency, where they have formulated evidence-based guidelines for the treatment of different rheumatological diseases, cross-collaborating with other similar organizations throughout. Dr. Shakaib is not only a national and a local speaker who has come across and given numerous lectures in UAE and Pakistan many times, but he has also been an active academician in the field of rheumatology and a noteworthy philanthropist when it comes to the recent developments and how these recent developments in rheumatology can be cross-collaborated in great association in countries like Pakistan, where he has extensively contributed in the recent years, while nurturing telemedicine as to be one of the biggest medicinal aids or bridging the gap between needy patients as well as the top specialists over there. Having Dr. with us is very privileged. Why? Because Dr. Qureshi is one of those individuals who has multiple exposures when it comes to geographies for rheumatology, because as many of you know, he is also a board certified rheumatologist in Malaysia. So given his years of experience in various geographies, he has learned the various aspects of rheumatology from a different lens. And today we are very privileged to have him with us. And I would like to thank all the doctors from across geographies who have joined in today's time to have this lecture session done with us. Thank you, Dr. Shakaib Quereshi, for joining us, giving your valuable time.
Good morning. First of all, I would like to thank you for such a elaborate and such a gracious kind of introduction. I'm deeply obliged. And I also want to thank all the participants, your team especially, who's taking such a great initiative in spreading the knowledge, medical knowledge across the board, especially in our South Asian community, Malaysia and UAE. And thank you for all the people who are listening today, because it's a weekend, I know, and it's a very precious time for everyone to spend with their family members. And I'm, very thankful to the people who have tuned in and giving their very precious time this morning. So you have chosen a very good topic, gout. There are a lot of misunderstandings about gout in the general population, some of the physicians as well, and then treatment protocols and stuff about mismanagement or misunderstandings about uric acid. Gout is a disease which is very close to my heart in that sense that it's a very treatable disease. You can make the patient satisfied and happy within a span of a few minutes, in fact, when they come to your clinic. Gout itself is a very prevalent disease. As we know, about incidence in US is about 4%. And I think the prevalence and incidence will continue to increase because of the dietary habits we have and the lifestyle that we spend now. Gout was called as diseases of the kings and kings of the diseases, means that signifying the importance of the lifestyle and the dietary habits as a link to the causation or finally the control of gout. So the important thing to remember is that there are two different things. One thing to remember in gout is one is the high uric acid numbers, and then there is a clinical conversion into a gout attack. The trouble I get into, especially in Pakistani population, is that uric acid is very commonly checked there and thought to be almost a cause of almost any pain that originates in your body, uh, which is why almost a lot of people, and where self-prescription is very common, and control over prescription is relatively loose. So I see a lot of people using, uric acid lowering medications, febuxostat and allopurinol in very variable doses without any evidence backed scientifically, and then with the potentially having more side effects rather than any benefit, and also at the risk of having a wrong diagnosis. For example, the bunions hurt, but that's not gout. So if you just have incidental uric acid number around 6 to 7 and you start taking it for a bunion, that's a lifelong medication, which is probably not going to help, and may have potential damage. So having said that, another thing which I noticed in the incidence and prevalence of gout when I spent my time in Kuching, Malaysia, was I was very amazed at the amount of of gout that existed in that population. It was an unprecedented and unbelievable amount of gout that I was in fact more known as a gout doctor there, because I did not even initially I thought it was a joke, but it became a reality soon, because almost everyone that I came across in that population of people that I knew had a very high prevalence of gout. Even in the female population, where we normally don't consider it to be a very high risk factor initially, at least in the younger age. So the gout, how does that happen? So it's primarily high risk in. So the process of hyperuricemia. Hyperuricemia basically mean a very high uric acid number, which over the period of time converts into a clinical gout. The studies have shown that the risk the high uric acid numbers start in puberty in males and after menopause in females, and that's why we do not typically see a high prevalence of gout in the females who are premenopausal. Uh, so having said that, the male incidence is pretty high. So we can see gout more in male patients at earlier age and female later on, unless there is an underlying enzymatic deficiency of genetic nature of AGPRT or PRPP, those kind of things, which are very rare. I've never come across, I think probably people who deal with the pediatric population or genetic disorders probably come across that more. So what are the risk factors? Gout is something which has been very commonly associated with something metabolically disordered. So a common metabolic disorder, such as there are certain risk factors which can be associated with gout. For example, hypertension, hyperlipidemia, hyperglycemia, which is diabetes, obesity. And so these are the things which are very commonly coexisting with the patient with gout. And patients with gout are at very early risk of heart disease that we have seen consistently, and renal failure as well. So this is a thing to remember also in gout patients. So what typically is an attack of gout? Gout goes through a long, the uric acid, hyperuricemia may stay in a very long period of silent condition, 5 to 10 years, depending upon the severity, and then it may convert into a clinical attack of gout. So the clinical attack of gout means as an acute monoarticular, typically monoarticular, only 20% of the patients at presentation have polyarticular gout. And so mostly as a typically a monoarticular, that means one joint involved in the beginning. Typically 50% start in the lower limbs, means like it's going to start in the ankle, foot, or big toe, mostly the big toe, which we call podagra. And the joint would be very acutely painful, severely painful, red, hot, swollen, and so much painful that the patient may describe that it's one of the worst pains in their life. Some people feel that their toe is probably broken, and they think that they have fractured their toe by any chance. Even a whiff of the air, the touch of a blanket, it can cause severe pain and hyperalgesia. The skin may start looking inflamed, and may even a little bit of sloughing may happen. Very commonly, it can mimic infection as well and cellulitis. And that's why the inpatient consults that we used to get were very commonly directed towards, initially the ID was called and they thought it was not typical cellulitis, and then we were called. So it can be, the whole foot can be painful, red, hard, and swollen. So, and fever. So the patients also get fever along with gout. So infection and gout can be very, looking similar to each other in the beginning phase. So if the first attack is not treated properly, finally the crescendo happens within 24 to 48 hours, and after 48 hours, gradually the gout attack subsides with or without treatment. Obviously, much quicker with the treatment, much later without the treatment. But eventually, the gout attack goes away, and this is a very important thing to remember in the history when you're referred any patient for any kind of inflammatory joint pain, to look at the history. So typically, the patient would have one or more attacks of monoarticular joint pain, and with pain and swelling, like the way I described, and then the patient can live a normal life for a while, and then until the second attack happens. Typically, if you do not intervene, that means that if you do not reduce the uric acid numbers, then the gout attacks continue to happen. And then a patient enters a stage which is called intercritical stage of gout, where the attacks are more frequent and they are long lasting than usual. And this stage can last for a while too, many years maybe. And if you still don't intervene, which happens many times, we see patients like that because they keep on getting the treatment for the acute attack. So they enter a stage called chronic tophaceous gout. Tophi are basically the collection of uric acid deposits in the extracellular fluid in the tissues and around the tissues, in the bone, the bursy, the muscles. They can happen deep as well as mostly superficial, lumps of uric acid deposition. They are mostly painless and mostly soft and non-tender. And that means that it's an advanced stage of gout. And typically, the radiographic changes have already started by that time, and you can see an objective damage of joints at that point too. As opposed to rheumatoid arthritis, gout radiographs are very different. Radiographic changes. Typically, the radiographic changes happen very late, and the joints are spared mainly even in the advanced stage, and the erosions of gout are very, very different looking than rheumatoid erosions. And another thing is that the bone density remains intact as opposed to rheumatoid arthritis imaging. So when you have an acute attack of gout, typically a male, typically a young man, first we diagnose the patient. So diagnosis is important. History is the most important factor, as I just described. Then you send the patient for, at the same time you order the blood work. The blood work that we order has to obviously rule out other potential causes of inflammatory arthritis. That's a good point to kind of start working it up, because we know that some of the other inflammatory arthritis can start in the same way, although gout is very typical. We still have to rule out the other things. So we do order the blood work related to all the other inflammatory disorders if they mimic or if there is a suspicion of them as well. And a full attempt should be made to aspirate the joint, because the gold standard is still getting the synovial fluid aspiration done, and then looking for gout crystals under the polarized microscope. The gout crystals are very typical as opposed to the CPPD crystals or pseudogout crystals, and they are negatively birefringent, and they are needle shaped, and they are yellow when parallel to the pointer, and blue when perpendicular to that, as opposed to the CPPD crystals, completely opposite. And the uric acid numbers may be artificially normal or low during an acute attack. What are the risk factors? The risk factors, obviously, the racial changes. For example, in Han Chinese, so there are modifiable and non-modifiable risk factors. What are the non-modifiable risk factors? That's something that you're just given, as a race, as an ethnicity, as an age. For example, male, if you are high risk, non-modifiable, age, young age, another thing is the race and ethnicity. as I said, that Han Chinese may have a very high risk of developing gout. African Americans have higher risk than white Americans. New Zealanders have a higher risk. Certain ethnic, Aborigines, tribals in different areas have a high risk. So those populations have a high risk of having gout. Then certain triggers, certain modifiable risk factors, for example, hyperlipidemia, hypertension, obesity, your lifestyle, your dietary habits, such as people who have a lifestyle of eating more red meat, shellfish, alcohol. But all this is going to happen in the background of a genetic predisposition. So you have to have a genetic predisposition to have the gout, and then all these risk factors play a very important role. So, and then obviously certain kind of dehydration can do that. Post-operatively, you can have a gout flare. Binge drinking can be a risk factor. So all these factors are modifiable, mean like you can counsel the patient, you can tell them that these are important. And once you, and then the high uric acid numbers. So you have, if the higher the uric acid numbers, more chances that this is gout, and it can keep happening again and again. So after you have established the diagnosis correctly, then comes the most important part, and that is, I consider that the most important part is education of the patient. In our very daily, typical busy practices, there is a very limited scope for education. I understand that part, but I can tell you the first piece of most important thing is to educate the patient about what gout is. I have handouts that I give to the patients in their native languages, as well as if ACR has patient handouts as well, and so many other resources where you can give the handout to the patient that what gout is. Unless they don't understand what gout is, the adherence to the treatment is going to be pretty poor. And that is one of the challenges, in fact, is the adherence to the uric acid lowering medication is very poor. And that is what results into a bad outcome of gout. So the patient education on the very first visit, because they have a very high reception in the beginning, they are open to all the discussion. They're open to talk to you when they are really having a lot of pain. So once you make that diagnosis, then you have to educate that, what is the difference between acute treatment of an acute gout attack versus chronic preventive treatment. Because if both are not done simultaneously, then the risk of moving towards more difficult to treat gout or more tophaceous gout will become more and more. So therefore, you have to talk to them about the diet at that time. A lot of conflicting data on diet, a lot of discussion about diet, a lot of overemphasis on diet also is there. So what I tell people is that the dietary part is where you tell them about, so their uric acid, basically the risk factor is high uric acid, and uric acid is derived from purines. But there are two sources of purines, the animal purines and the plant purines. So the animal source of purines, especially coming from the red meat and shellfish, has to be mitigated. You have to either eliminate or try to reduce it as much as you can in the smaller portion and more, less use than mostly, and minimize their usage or consumption. And also shellfish. I have some patients who say that I ate like prawns, and within an hour I started having a gout attack, or they ate a crab or something, or lobster or something, and within an hour they would have a gout attack. So those things have to be kept in mind. And then binge drinking, drinking beer in large quantities and binging them is a high risk factor, along with routine liquor. So those are the risks. And then you have to counsel them in the beginning. And the important thing is that the same things that you tell them about gout and dietary modification help them to reduce their risk for heart disease, which is a very high risk in these patients. So I convince patient by telling that this is not only a gout treatment, but your risk of heart disease, which can be fatal eventually, also goes down if you really follow that diet. The DASH diet, for example, is another thing it can be helpful, where you basically reduce the amount of sugars, and it's more like a fruit and plant-based diet, and more nuts, etc. Where you also reduce the salt, and hypertension, but at the same time, the gout risk may go down with that kind of a diet. But typically you can only tell the patient so much so that the diet does not become unpalatable too. If you make the diet very unpalatable, the patient is not going to listen to you, and in the long run, it's not going to work. You also can counsel them about obesity and weight loss in the very beginning. The studies have been done where they've seen that weight loss surgery, bariatric surgery, and losing weight on more regular basis, like the goal should be about 3 to 5 pounds per month and coming closer to their ideal body weight if they can, has really reduced the amount of hyperuricemia and the repeated risk of gout and better control of gout with or without medication. So, but important thing to remember is that patients who have repeated attack of gouts, the stringest and the strictest of the diets are not going to reduce the uric acid more than 1 milligram per deciliter. So it's not going to make a huge difference. So that's the most important part. That you have to remember that diet is important, but it's not the ultimate treatment. But the patient would have a bunch of these questions to you. There are questions about coffee and certain other things which so the coffee, for example, higher consumption of coffee, 4 to 5 cups of coffee may actually reduce the level of uric acid. But again, this is not something that you would do just to reduce the uric acid and hypercaffeinate yourself. Vitamin C has been studied and may have some some uric kind of role. And then, for example, when you're choosing an agent, a hypertension agent, losartan might be a better choice because it has modest uric effect. So that might be one of your good blood pressure medication. So you can change their thiazide diuretic if it is if the hypertension control can be achieved by losartan. Not only, but if thiazide diuretics are must, then obviously yes, you have to continue them, or loop diuretics. Potassium sparing diuretics actually are not a risk factor as compared to thiazide and loop diuretics. So in case you have to use diuretics, that could be one of the potential choices. Then, other than these general measures, you have to treat the acute attack. So I mentioned that when you're aspirating a joint, then inject that joint, especially more feasible when a larger joint is involved, such as ankle joint, you have knee joint, elbow joint, wrist joint. I have tapped even the the MTP joint, and it's very painful. So I typically do not push that too much because I know that that's going to be very painful, and you're hardly going to get 1 or 2 drops of synovial fluid, and that can be pretty brutal when somebody's got an acute attack of gout. When you aspirate a larger joint of gout, you can inject it too, and that's where patients are so happy. They come limping in your office for the last 7 to 10 days. They're miserable. You tap a knee joint or more than one knee joint, and they go back home walking normally. There's never a happier patient than that, let me tell you that. So you can do that. If there is no contraindication for the NSAIDs, non-steroidal anti-inflammatory drugs, you can use naproxen or a similar medication, and you can use it until the acute attack is gone, and after 2 or 3 days afterwards too. Colchicine is still an agent that you can use when the gout attack is about to happen. Typically, the very large doses that were used to be given in the past are not recommended and have no evidence base. So we give them 0.6 milligram, 2 tablets immediately, and then another tablet after an hour. So 1.8 milligram in the 24 hours, and then 0.6 milligram twice a day until the attack is gone. And then you can use steroids when the NSAIDs or colchicine are contraindicated or not effective enough. Then you can use oral intra-articular, parenteral steroids, and then that attack can be, the resolution can be achieved of an acute attack. After an acute attack, is the most important that you prevent the chronic recurrence attacks. Recurrent attacks. For that, you have to choose your uric acid lowering medication. So typically, a uric acid lowering therapy requires the use of allopurinol or febuxostat. And typically, these agents, if you have to choose between the two, the ACR recommendation is to choose allopurinol in the 2020 guidelines because of limited evidence that the fluoxetine may increase the risk of cardiovascular events by a smaller amount as compared to allopurinol and all-cause mortality. So it's still recommended now to start with allopurinol, and I typically start allopurinol as opposed to other. The recommendation is to start right when the attack is happening. Yeah, or in the phasing stage of gout because acute attack, because at that time the patient is most receptive that he's going to start the treatment, and there's a chance that he will stay on it as compared to if he's gout free and then he's feeling fine, he or she may not even start gout treatment. You start the allopurinol or fluoxetine according to your the risk factors that I described about, and then once you start them on it, low dose. I start with a low dose and I keep titrating the dose upward until the treat to target dose, which is or range of uric acid, which is as uric acid less than 6. I preferably try to keep it around 4 is achieved, but gradually. The most important things to tell to the patient and the physician should also be receptive to that is that it's going to be taking time. I always tell patients that you have to be patient. You have to tough it out for a few months until you will have your disease-free long-term situation arise. And typically, when I start allopurinol, I give them a prophylaxis. There is not a contraindication. It's colchicine for 3 to 6 months, or we can give them NSAIDs if colchicine is contraindicated for some reason, or give them a backup of steroids if the acute attack of gout has to happen. The other medications are contraindicated. So once the acute attack of gout is taken care of, the chronic treatment has been started, uric acid level comes back to where you want it to be, the attacks of gout will go away, and the profile will reduce eventually. There are some other medications which are also clinically available but hard to use. For example, pegloticase is available. Very rarely that gets used because of the high risk factor associated with the anaphylactic reactions. And it's a tough medication to use in the patients who have contraindication to all the other previous medication, and the targets your guests cannot be achieved, but they continue to have polyarterial gout and they have renal issues where the medication are just not effective. Then another case can be used, which has a high anaphylactic, as I said, reaction, but it can dramatically melt down the profile and can dramatically reduce the uric acid levels down. And so that's one of the available drugs to be used. The IL-1 blockers, IL-1 blockers such as anakinra, and so they can have a role potentially. Secukinumab may have a role in acute attack of gout where it's just not going away, or there is a contraindication to all the other acute attack treatment protocols, and the incidence is cost and availability of these drugs in many countries. So, I can tell you another very important factor to remember, which I've seen very rarely. Some mistakes have happened where I've seen the patients on a secondary basis, secondary or third concerts. Uh, can you hear me now?
Yes, doctor. I think there is some disturbance in the voice that is coming from your end. So, let me check once. Just a second, doctor.
Sure. Take care.
Yeah, yes. It has been for a while. So what we can do is maybe you can just disconnect for a second and rejoin. Yes, we will be in the live feed. You can do that, doctor. You can do that. Yeah. Yes. So please, everyone, stay tuned. We are just temporarily facing some technical issue. So the doctor is rejoining again, and we will again continue with our discussion. Hello.
Can you hear me?
Yes, yes, this is perfect, doctor. We can continue. You can continue for 5, 6 more minutes, and then we will start the Q&A. Yes, yes. Yeah.
Got it. Sorry about that. I hope that everybody can hear me now. Again, sorry for the trouble we were having. Basically, I was talking about the acute treatment and chronic treatment of gout. I was on the topic of IL-1 blockers that can rarely be given for acute treatment. Again, the amount of, the availability of the drug is the issue, and the cost. And so they have a certain particular role, but not always. Yeah, another thing I was talking about is the polyarticular fashion. So some patients present late, and some patient may never be diagnosed until the late stage, and they develop tophi in the hands which look like similar to rheumatoid nodules. And I have seen cases very clearly where they have been misdiagnosed as seronegative rheumatoid arthritis by even rheumatologists, and they were on anti-TNFs without much good results, and they continue to have more tophi. We have seen actually a case of spinal gout, which is very rare, which we presented to one of the local chapter meetings, and in fact won the first prize. And we actually insisted the neurosurgeon to tap that area, and we were able to obtain the gout crystals through that. So there are oddballs there. Polyarticular gout, as I said, mimics rheumatoid arthritis. And in the very beginning, I mentioned about X-rays, the role of X-rays and imaging in the later stages. Ultrasound has been used, as well as MRI scans, where the cases are difficult to diagnose based on the non-availability of a joint tap because of the multiple small joints involved. So this is something, chronic tophaceous gout, which is very important to remember. In Malaysia, I've seen tremendous advanced cases of chronic tophaceous gout. As I said, that in that particular population, Indonesia, Malaysia, I found a very high incidence of gout. Hence, their chronic tophaceous gout incidence is pretty high. So these are the points to remember, and also to remember that gout patient is your patient for life. You can't let them just get the acute gout treated and then forget about them, because they may come back after many years with a stage of gout where it will become therapeutically very challenging to give them the medication that otherwise would have been very effective and easy to give in the beginning. So I think I would like to stop there and try to take more questions so that we can keep it interactive and interesting.
Yes. Thank you, Dr. Shakaib, for sharing your clinical experience with us in terms of diagnosis and management of gout. Now we will take the questions from the doctors. So, Dr. Shakaib, one of the questions which the doctor has asked is, can you please share some indications for the optimal use of ULT therapy in managing gout?
Yeah, so very good question. So that's the primary thing, is that when I started my talk, I opened it up with the indiscriminate use of ULT, the uric acid lowering therapy, and self-administration of these medication in our patient population, especially in Southeast Asia. I see in Pakistan, it's a drug which is available right and left over the counter, and so many different low quality forums or medical forums can also, where people are just answering all the questions of a patient without their background knowledge. They just indiscriminately give uric acid lowering medication also. So it's so important to have the judicious use where the clinical indication is there, and not using anyone who's just hurting and has incidentally a slightly high uric acid number, 7, 5, 7, 8, 8.5 or so, but never had a clinical gout. So those patients, you're not going to be using uric acid lowering medication indiscriminately. But anyone who has 2 or more attacks of gout in a year and has hyperuricemia, documented attacks of gout, you are going to start using uric acid lowering medication. And I already touched upon the different ones available, such as allopurinol, febuxostat. Now, probenecid is available typically, historically. It gets used very less, because in the long run, due to the comorbidities that we have in gout, due to the incidence of renal failure we have in gout, and due to the drug interaction probenecid can potentially have, the usage is found less. I've used more in Malaysia though. I've assumed probenecid in Malaysia, it's very effective in the Malaysian population for some reason, because for some reason, again, something that I'll dig into in the later part of my career there, is that the patients there are very sensitive towards even a low dose of allopurinol and hubroxostat, and they even get like jaundice and liver function abnormalities very quickly with them. And even and probenecid has been found to be very effective, and that's the most fascinating part of gout and its treatment and treating in different countries is that the incidence, the prevalence, how the patients behave, how the risk factors are different in different countries. It's an amazing thing to notice. So that's what I would say about the ULTs. And obviously, I talked about Cristex, the pegloticase, that how effective it is, but how risky it can be.
Right, doctor. So, doctor, this next question is because I think this is on a very similar lines when you were discussing or highlighting on colchicine. So, this particular doctor has mentioned that what are the advantages of recommending colchicine to the patient suffering from gout as compared to the use of corticosteroids?
Very good question, in fact. So, and that's why as physicians, we have to take a very good history and we have to assess the risk factors. For example, somebody has, hyperglycemia, has diabetes, and there's a contraindication to NSAIDs too, whether that be GI bleeding or something similar to that. Colchicine can be very effective. Colchicine, as I've already outlined the dose and how you have to monitor the dose, make sure that it's not used, in improper dosages, because in the past, in fact, you would not believe it, years ago when I started my career, parenteral colchicine was available. It's not available anymore because of its high toxicity. It can lead to blood dyscrasia and then bone marrow suppression and death. In fact, if you use it without when it was available improperly. So colchicine is it's one of those drugs which has been available for a long period of time, like for years and years. And in the countries where it's cheaper and easily available, it's very important to use in acute prophylaxis. But it's most effective when the patient takes it in the very beginning stage of gout for an acute treatment. And it, as I just mentioned, that it can also be used for prophylaxis while you're reducing the amount of allopurinol or the uric acid by using the ULTs. The colchicine can be given as a prophylaxis, 0.6 milligram twice a day for 3 to 6 months until the gout attacks completely subside and the target uric acid levels has been achieved. So yes, colchicine is very important.
Right, doctor. So, doctor, the next question, now this is a situation which the doctor has presented is like in majority of the cases, this particular doctor is recently encountering a lot of young age gout diagnosis. Now, technically majority, what the doctor has mentioned that one of the cases where he has experienced that this particular individual is working 14 to 15 hours a day in a sit back position and physical activity is almost negligible. Interestingly, with this also there is a past history when it comes to habits for alcohol intake on a weekly basis. Now, in this particular case, what has happened is the patient has come in a bit late, though he had uric acid, highlighted earlier also in his CBC tests, and the patient has given a situation that maybe since he has a stressful work life, maybe stress is something which is elevating the uric acid rather than anything which can be considered as a comorbidity, as a direct indicator. The doctor is asking that, a psychological evaluation and convincing the patients become very challenging in this case, because the patient is not ready to accept that he or she has gout. How much of a psychological intervention is critical for a specialist in this particular case to manage effectively?
Amazing question. You mean like this is something very close to my heart, because I see a psychological portion being ignored by the doctors mostly, and I'm so happy that this physician is in fact thinking about that, because if you really look at it from the long-term perspective, I said that the adherence to the ULTs is very poor in most of the patients. Several studies have shown, and observational studies or otherwise, that the patients normally are not taking the amount of medication or the dosage of the medication as you are giving it to them. When they are in the silent phase of the disease, they forget it. I mean, like they think that everything is gone and they're okay. And it's a human behavior that eventually those drugs will go, and they will not be adhered to, and they will keep on having attacks. So you have to really ask them about what exactly are the roadblocks. And one of them would be, our patients with chronic pain or chronic issues, they are very commonly depressed. So you have to really ask them exactly that, if you are not treating the underlying psychological, lack of motivation, for example, the patient may be depressed from having disease or other reasons in their life that they're not compliant with the treatment. So to treatment of the psychological issues, and first of all, the identification of those psychological issues is the most critical. Whether there is an underlying psychological issue which might be hampering the patient's management decisions, or sticking to a treatment schedule. So I'm very happy with this question, because this is what mostly people ignore because of the lack of time available in the clinic, or maybe something that we ignore normally, because there's a human element, there's a psychological element, and there's a body element. So we always think more about the body and objectively visible things. We do not think about the barriers, psychological barriers that might be, whether they be more like a lack of understanding of the disease, or maybe fear of the disease, fear of the medication. And obviously, this particular patient that the physician is talking about most probably has some underlying psychological issues which has to be sorted out and properly addressed. And especially, I think in this particular role, I think more than psychological, what is probably causing, if you really ask the otherwise risk factors, is I think the sedentary lifestyle. As I said, this is a disease of the kings, not be the very sedentary lifestyle of the kings and the position in power, which probably is changing now that they are very aware of the health issues also, is that the lack of proper exercise. As I said, obesity is a risk factor. So if you're not exercising enough, your cardiovascular risk goes up, the hypertension, the metabolic disorder, what I told you about, the whole syndrome associated with it, the risk goes up. So I think this particular patient should be definitely, looked at from psychological point of view and should be treated accordingly, and then should be really encouraged to change the sedentary lifestyle. There are some kind of suggestions that even those sedentary people, if they have a desk job, they should stand up for 5 minutes every hour and do some kind of a rigorous physical activity, and then they're going to come back, and that actually they may get better results than 20 or 30 minutes exercise on when they're getting it continuously. So even if you keep yourself busy and you keep your number of steps, and you keep some excessive physical activity after 5 minutes, whether that can be a brisk kind of a exercise, that might be suggested in this case. And exercise, as we know, commonly can reduce the psychological burden and depression as well. I hope that answered the question.
Sure, doctor, that did. So, doctor, the next question is from a physician, where he is asking that when we talk about synovial fluid test for diagnosis of gout, how is your perception regarding this particular test?
Yeah, it's a very, very vital test. Like as I said, like when the joint is available to tap, and if it's easily tappable, you can do a joint aspiration. I always do it. But like, there's no doubt about that. Even if it looks like gout, it talks like gout, walks like gout, you got to get the synovial tap done if you can. And, the advantages are that you're going to decompress the joint, you're going to rule out an infection, and then you're going to look at the crystals and then confirm the diagnosis. And, I typically have a clinical experience where I can clearly tell whether this is gout or not. Not that I recommend that everybody should inject the gout right away. I over the years, 20 years or so that I've been doing it, I typically know exactly what, and if I feel that this is 99% gout, I inject the joint at the same time, which I would not recommend to the people who are not used to doing it, because you have to rule out infection before you inject the joint. And then the patients, they get very good results. It's actually one of the therapeutic options of resolving an acute attack of gout.
Right, doctor. So, doctor, this next question is from a doctor who is asking that should a person with allergy and inflammatory condition be screened for gout? And if it is, should early preventive interventions be planned for such patients?
So you said allergy and inflammatory condition. Did they say what inflammatory condition? Like, is it asthma or something?
Yes. Mainly pertaining to asthma.
So in the field of, if you ask for dermatology things, so the field of in that is actually psoriasis is one of the risk factors for gout. So the patients who have psoriasis, I know that psoriasis is not an allergy, but the folks who have skin psoriasis uh, should definitely are at risk of having gout if the clinical picture is compatible. So you always have to tap a joint. In those cases, become very important to tap a joint. But remember, in psoriatic patients, when you're tapping a joint, do not go through the skin lesions. That's very, because otherwise you're going to introduce the skin, infection into the joint. So it should be done by a very well-trained person. Allergy and allergic situations, I'm not clearly sure about that. I don't, unless there is some literature search that I can do later on for this particular question, but I'm not 100% sure about that particular association.
Sure, doctor. So, doctor, I think in the start of the session, we have discussed about this one particular topic to have a broader scale of lectureship done in the next series. But one of the doctors have asked that when we talk about gout and pseudo gout, is the management almost the same? So, yes.
Yeah, so this is very interesting. I was talking to you folks about, what should be the next lecture series. And we discussed about, so one of the reasons to tap a joint, as we just talked about, is to differentiate the other reasons. And a pseudo gout is a very important topic, which I had some very interesting cases, and I had a lecture series on that. Is that because it's an entity which can, first of all, it's a misnomer. There's nothing like pseudo gout. It should be called CPPD crystal disease, because pseudo gout is only one of the mimics of CPPD crystal disease. I've seen some fascinating cases. I mean, like CPPD crystal disease can mimic gout, yes, but it can mimic osteoarthritis. So there is a pseudo gout presentation, there is a pseudo osteoarthritic presentation, there is a pseudo rheumatoid presentation, there is a pseudo ankylosing spondylitis picture presentation, and there is a pseudo septic presentation. I've seen actually pseudo septic in the inpatient case scenarios and settings, and becomes so important to, like, high fever, polyarticular involvement, looks like a septic joint, or and then turns out to be it's CPPD crystal disease. The most fascinating presentation, when we will do the lecture series on that, hopefully in the future, is what we call crown dance syndrome. It's a very common question asked in rheumatology circles, at least, probably not for the general physicians. Is that where the patients can have this very fascinating deposition of the CPPD crystals around the crown and dance area, in the dense area around in a crown-like fashion, and which can be radiographically fascinating looking, like, especially MRI will make that diagnosis. Patients in typically an older patient present with severe fever and pain, and mimicking like an infection of the spine, and they respond dramatically to the steroids or NSAIDs, and it's a very fascinating disease. So that we will reserve for as a separate whole topic if you guys are interested in that. But this is in a nutshell about CPPD crystal disease.
Sure, doctor. So, doctor, this next question is more of a statement which the doctor has mentioned, and he wants your view on this. What the doctor is saying, that it is important for people with gout to continue uric acid lowering medications even when hospitalized.
Yes.
So, what is your view on the same?
Very common scenario, again. The thing is that the patients who frequently get gout attacks, we should not stop their allopurinol, because they can be practically stopped. I typically do not stop them, and it's a common scenario that people keep stopping it unless there is a clinical contraindication to stop them other than gout. For example, they're having a hypersensitivity reaction, or there's other kind of. For example, I didn't touch upon some complicated topics, which we can, but they're very situation oriented. For example, allopurinol hypersensitivity syndrome. That's a whole different topic, very common. Remember, allopurinol is not like a completely, like it's not a candy. So some people, especially with HLA, special genetic predisposition, I think it's 5801 or some genetic allele, which you can clinically test in certain high-risk patients. For example, in African American or I think it's in Korean or Chinese population, where they're high risk of having this genetic allele, 5801, I think. B5801. So they're at high risk of developing the hypersensitivity reaction, which can be fatal. So unless you don't have that contraindication or any other reason to stop, I would continue.
Right, doctor. So, doctor, the next question is focusing on flares, when the doctor is asking, in your opinion, how gout flares can be prevented, and in particularly these conditions, what are the short-term as well as the long-term strategies?
Excellent question, Milak. So that's the most important part. As I mentioned in the beginning, that the acute attack is not the only thing you worry about. You have to make a long-term plan. In the long-term plan, the education is the most important. You give patient education resources. Depending upon their education level, also you can make them more palatable. You try to use their own language. I'm kind of blessed that I can use Urdu, Punjabi, Hindi, and English. So typically, whatever their language that they understand, and according to their educational status, you can make them more palatable and easy for them to understand. So the most important part is the very first attack, when the patient is really receptive to listen, you educate them. And the second part is that you tell them about how to risk mitigate. So not only that you tell them about gout, you tell them about hypertension, you try to tell them about hyperlipidemia, hyperglycemia, obesity, diet. This is the time you tell them. So you tell them about that if you don't change your lifestyle, if you're not going to make some small changes, where you can have a better outcome eventually, not only gout-wise, but in all those clinical risk factors. And you tell them in the very beginning, and then try to address them. As an internist, I try to tell them or guide the referring physicians about them, how to change. For example, if they're on hypertension medication, as I said, if there is a choice that they can clinically, the diuretics can be changed, thiazide or loop can be changed clinically. And if they're clinically indicated, there is a reason, congestive heart failure, whatever, they have to be continued, then they have to be continued. But if there is a chance that you can change it to losartan, it's a better drug. The ACR guidelines about having, the lipid management, it's kind of the Tricor, for example, was one of those drugs that has some role. He can actually, because right now they have their own indications, and just to give them a uric acid lowering wise, you can recommend that for just that alone. So I think, and then long-term goals is to keep them gout-free. So sticking to their uric acid lowering medication, telling them about what are the benefits, what are the risks of keeping, if you keep the drug forever or for long term, versus keep not taking the right dose. What are the risks involved? I many times actually, in fact, show them. I have pictures of my real patients. I have some videos of my real patients, obviously after the permission and stuff and hiding their identity. I clinically show those videos, especially I have some videos of the Malaysian patients. I show them the patients, this is what's going to happen. I have a patient of gout that I tapped about, my record was about 250 mLs in one go from one knee, like 20 cc syringes, 12 in one picture. I show it to them that this can happen. I show them the chronic tophaceous gout pictures, that you have to have that a little bit of scare element in them too, that this can happen eventually if you do not keep in your treatment, if you keep ignoring the long-term treatment. So adherence to their uric acid lowering therapy, losing weight, managing their diet properly, and proper follow-up is the most important. And then obviously also measuring their uric acid numbers whenever you change your medication dose until you reach the target dose is also important. So make long-term goals. That's very important.
Right, doctor. So, doctor, this question is very interesting. I think it is again related to practice management. So, one of the doctors has mentioned that one of the reasons that he found out that why his patient reported late with the high incidence or the high record of uric acid in after his CBC was that the patient has said that usually, majorly, everybody does Google search in today's world, and he found out that one of the top, maybe indications for high uric acid could have been cancers also, certain form of cancers. And the patient was mentally devastated by creating a hypothetical scenario that maybe he has an underlying condition. The doctor suggests that, generalized education or generalized pointers are always there in the Internet of Things, but how as a clinician or a physician, obviously in line with patient education and giving the patient an understanding about such a critical disease that is cancer, which is very complex in itself, how to differentiate and make the patient understand that even simple form of disorders can also lead to this form of criticalities. Not exactly everything will lead on to cancer.
I think it's a very important question. I'll give you actually my own analogy. When I was in the fourth year, I thought that I had a melanoma. I was going through actually a dermatology rotation, and I thought I had a melanoma in my, the pinky toe. So, and it was actually, so I was very, very nervous about it. I thought that it was black. It was something which was, not there a few days ago. And I was going through, and I went to my dermatologist in my in my college, medical college, and he laughed at that. It was just basically a trauma to my, subacute trauma, which led to some bleeding and accumulation of, the blood underneath that, giving a darker appearance after a few days. And he called it a fourth year syndrome, fourth year medical student syndrome. So yes, Google searches are very important. But let me tell you, they can be very misleading and many times because depending upon what the patient's fear factor is, their understanding is, their educational level is, their way of interpreting things is, they can wrongly associate things with such common things. For example, I just mentioned about indiscriminate use of uric acid lowering medication in Pakistani population is just horrendous. It's unprecedented. Like I had never imagined that existed that much when I started working back in Pakistan since 2018. Google, that's why when I give education resources, I give patients, I use, EULAR, I'm sure they have it. American College of Rheumatology has some very good patient handouts. Up to Date has it. A lot of other reputable Medscape has it. So I try to give those evidence-based resources to them, and try to educate them based on medical literature rather than just a certain guesses that they exist in the community. Otherwise, yes, there are certain cancers which can lead to gout, and that might have led to the misunderstanding of that particular patient. For example, there's a tumor lysis syndrome is a known thing in which can cause acute kidney shutdown, and gout is a syndrome that happens in the myeloproliferative. For example, the treatment with very large burden of disease such as Burkitt's lymphoma or ALL, where you're giving them chemotherapy and their cell breakdown and they release all the toxins along with uric acid, all the cell components. And then what happens is that they can have acute rise of uric acid and have the kidney shutdown. So those are the patients where the patient might have looked that up and tried to get scared about the cancer and association with the gout and stuff. And the tumor lysis syndrome is a topic by itself. It has to be treated in conjunction with the hematologist or oncologist. They typically know what to give and how to treat it. So a whole separate topic which a patient does not have to be educated with, because unless they don't have Burkitt lymphoma or treatment with lymphoma is going on or leukemia is going on. So so the patient has to be reassured that there's no risk of cancer with gout or treatment of gout.
Right, doctor. So doctor, this next question is from a doctor who is asking that, can you please elaborate on the latest EULAR recommendations for managing gout?
Yeah, I mean, I actually must say that I mostly am familiar with the ACR guidelines. This is something I can get back to them. If you give them my email or my contact, then I'll be very happy to give them the EULAR guidelines as well.
Sure, doctor, sure. So doctor, this one last question that we have received is one of the doctors is asking, when we talk about diabetes mellitus in today's world, now a lot of reverse engineering logic is being played. So is there any study which is actually shedding this confirmation light that gout may lead to diabetes or diabetes also may lead to gout? Because obviously a genetic variation is an angle which these doctors or researchers are looking at.
So as scientists and researchers, now we always form a hypothesis and then we try to move towards confirming it. So I think it's a good hypothetical situation. Then what if gout caused diabetes, or diabetes caused gout? And I think this will need more research, more collaborative work through endocrinologists and rheumatologists to come to that conclusion. But these two common things are very common. I've seen the gout patient eventually get this metabolic syndrome, the hyperglycemia, diabetes, heart disease, strokes, and all this is the same disease, metabolic syndrome, which is happening. So I'm sure that as we go along, we'll find more and more associations. Recently on that topic, colchicine, recently there was a study which showed that the colchicine may actually, when used in post-operative cabbage patients, may reduce the risk of cardiovascular events. So there is, yes, the underlying disease process seems to be about the same in all these different, comorbidities. And so I think we'll find more and more, as the more and more literature happens in this direction, we'll find more answers.
Right, Dr. Shakib. So, Dr. Shakib, on behalf of the community, I would like you to share a message on this Gout Awareness Month. Given your years of experience in various geographies, if there are a few lines you would like to mention to the physicians on our platform.
Sure. First of all, I would like to thank all the physicians again, because, as I said, like, very beautiful questions asked, very intelligent questions asked. And again, thanks to them for tuning into this Saturday morning. And I'm sure I wish them happiness, and I wish them to spend their time with their beautiful families and take care of their patients as always. As I mentioned in my last situation, like last lecture as well, was that we are healthcare workers right now are heroes. They are taking care of the very sick patients. The COVID-19 situation brought a special subset of people amongst us who are frontliners and taking care of those patients, risking their life. So even though it's a gout topic, but let me tell you, I can't give them enough credit. I can't give enough credit to people in India, Pakistan, UAE, Malaysia, because there were very less PPEs available. Right now, India is going through a very difficult situation. Breaks my heart, and salute to those heroes who are taking care of those patients as frontline. How much they get exhausted. They're human beings. They're risking their lives. Lives have been lost. So that is one thing I wanted to say, to take this opportunity to thank them. That, and also that remember that gout is a very easy disease to treat, but still has a lot of misunderstandings. A lot of different guidelines are not properly followed, which may result into. And again, one of the frustrating things that I particularly feel is that in the future, I expect and I really pray and hope that more and more therapeutic options will come into picture, because this was a disease therapeutically was ignored for years and years. There was only like colchicine and allopurinol and probenecid kind of available. Even febuxostat came while I was actually, after my, my life as a rheumatologist had started. So, the therapeutic, and then came pegloticase, which has very limited scope again. So although we have come across, we are trying to make, advances in gout, understanding it, more evidence-based. For example, previously we used to just tell about, gout and, the diet, and now we have more evidence-based things on that. So I hope when we'll be doing another lecture in gout next year or whenever it's feasible, we will have much more medical literature available. And hats off to all those folks again who are doing such a good job in all these countries. And thank you for giving me the time to talk to you.
Thank you, Dr. Shakib. On behalf of MedSynapse community and all the physicians across the world, I would like to thank you for sharing your gracious time to have this insightful discussion. And belonging from that medical fraternity, I think we all can resonate in our hearts that, learning, or this continuous learning, most blessed terms that is there in medicine. And it always surprises us when we start learning from our seniors that how treatment is seen from a different lens, in a better way, from each angle. And thank you so much for giving your precious time today. And I would also like to inform the viewers that in the future also, we are planning more such activities with Dr. Shakib. One of the things that he mentioned is pseudo gout, which we will be planning very soon. And also to celebrate the month of October, which is focused on Rheumatology Awareness Month, we will have few series with Dr. Shakib also from his expert insights. So please stay tuned. Follow Dr. Shakib as well as the MedSynapse community clinical knowledge sharing on our platform. Thank you so much, and take care, everyone. Thank you. Thank you, Doctor.
God bless you. Thank you.